So this is the benign serous adenoma. What is very important, you can see the surface of this tumor. It is highly what? It is highly smooth and it is glossy, glistening in nature. Can you see any epithelial thickening? You cannot see any epithelial thickening over. This is the high-grade serous tumor showing more complexity, and the most important feature, if you see, can you see this?
Invasion of stroma.
So invasion of the underlying stroma is present. This is the stroma as we can appreciate from this diagram. This is the classical stroma as we. So we are starting with the ovarian tumors, and it is a very interesting topic, and a lot of exam MCQs will be covered in the basics part only. So about the ovarian tumors, around 80% of the ovarian tumors, they are benign in nature, seen in young women between 20 to 45 years of age. So these are the benign set of ovarian tumors. Usually, majority of the ovarian tumors, they are epithelial tumors. And any of the epithelial tumors, they are of three types in case of the ovarian tumors. They can be benign, they can be borderline, or they can be malignant. So the benign tumors, they are in young women between 20 to 45 years. Borderline tumors, they occur in slightly older age group, whereas the malignant tumors are seen in the age group 45 to 65 years of age. Now, ovarian carcinoma, if you see, they are accounting for approximately 3% of all the cancers in females. Okay, and it is the 5th most common cause of death due to cancer in women. Coming to the classification of ovarian tumors, just follow what I am showing you. Don't have to go through any other classification. This is the simplest classification, and all the questions, they will be based on this. Everything is covered in this particular chart. So over here, again, very important stuff is that there are 4 important groups of tumor. The first one is your epithelial stromal tumor. Second is your sex cord stromal tumor. Now, the epithelial stromal tumor, it is arising from the surface epithelium of the ovary. The second is your sex cord stromal tumor, which is arising from the ovarian stroma. The third is your germ cell tumor arising from the germ cells. And lastly, you are having the metastatic tumors to the ovary. So germ cell tumors are very, very important exam question. It is a very, very hot topic. Okay, very, very hot topic for the exam. Now, among the epithelial stromal tumor, remember, out of all the tumors, as a group, I am saying, as a group, this is the most common group of tumors. So the epithelial tumors, they comprise around 60% of all the tumors of the ovary. Okay, and among the epithelial tumors, you are having serous tumors, mucinous tumor, endometrioid tumors, clear cell tumors, transitional cell tumors, and epithelial stromal tumors. Among the sex cord stromal tumors, you have the granulosa cell tumor, fibromas, fibrothecomas, thecomas, Sertoli Leydig cell tumor, and you are having steroid cell tumor. Among the germ cell tumors, we have teratoma, monodermal teratoma, dysgerminoma, yolk sac tumor, and mixed germ cell tumor. Among the metastatic tumors means, see, all these ovarian tumors that we are talking about, these are nothing but adenocarcinomas. Now, how do you think sometimes what will happen? Adenocarcinoma in the other side, for example, from the colon, colonic adenocarcinoma might metastasize to the ovaries. Yes or no? It can happen. Similarly, gastric carcinomas can also come. So metastatic tumors are also very common in the ovaries, like from the GIT, like from the colon, from the appendix, from the breast, pancreas, and biliary neoplasm. Also, these tumors, they can fly and they can enter the ovaries, okay, as a metastatic tumor. Okay, one very important thing, a clue to the diagnosis of the metastatic tumor is that if you see in case of the metastatic tumors of the ovary, okay, around more than 50% of the metastatic tumors are bilateral. Okay, so this is the very, very important clue to the diagnosis of metastatic tumor of the ovary. Okay, some more important MCQ that I am going to discuss over here is that, okay, if you see the most common category of the ovarian tumor, the most common category I have discussed, the first important MCQ are the epithelial tumors of the ovary, which is comprising approximately 60% of all the ovarian tumor. Among them, if you see, among these epithelial tumor, the serous and the mucinous cyst adenomas, okay, they are the most common. The serous and the mucinous cyst adenomas of the ovary are the most common, and they together constitute 30% of the ovarian tumor. So remember over here, the most common group is epithelial, and among epithelial, the most common is serous mucinous, and together these are constituting 30%. Okay. The most common category of the ovarian tumor, as I told you, is the epithelial tumor. Okay, and this is basically it is accounting for 60% of all the ovarian tumors that we see. And among these epithelial tumors, if you see, among them the serous and the mucinous cyst adenomas, as I showed you over here, these two tumors together, but they are together, not individually. Together, they are constituting 30% of all the ovarian neoplasm taken together. So these are the very common. Among the sex cord stromal tumor as a group, they are constituting 9% of the ovarian tumors. And the most common sex cord stromal tumor, if you see, there is the granulosa cell tumor, accounting for 1% of the ovarian tumors. Now the single most common. Now, for example, over here, if I have to choose any single out of all these, if I have to choose a single tumor, which is the most common ovarian tumor, it will be benign cystic teratoma. It will be benign cystic teratoma. The single most common ovarian tumor is the benign cystic teratoma, which is the germ cell tumor. It is comprising 32% of all the ovarian tumors. These three MCQs are the tried, tested questions asked again and again every year. Nothing comes out of this. Okay, these are the only important MCQs that you should remember. Okay, remember, germ cell tumor as a whole group, it is very rare tumor. Other germ cell tumors are also very rare. But the benign cystic teratoma, it is the single most common ovarian tumor that you are going to see. Are the MCQs very clear? See, this is the common ovarian tumors with their relative percentage. See, the benign cystic teratoma, it is comprising 32% of all the ovarian tumors. Whereas I told you the serous and the mucinous tumor together, they are constituting 30%. Yes, I have already explained. Okay, now very important other thing that we have to appreciate is that out of, so these are all the different groups of epithelial tumor along with all the other tumors. The serous epithelial, mucinous, endometrioid, undifferentiated clear cell carcinoma, granulosa cell tumor, teratoma, metastatic tumor. Now the first I am going to see on the left hand side, we are going to see what percentage of all these tumor classes are malignant. Okay, and what percentage are bilateral. So you have to understand, in case of serous tumors of the ovary, as you are going from benign to malignant tumors, you are going to see that the incidence of bilaterality is increased. So the malignant serous tumors, 65% of them, they are bilateral. Okay, now in case of mucinous tumor, if you are going to see, okay, you are going to see very less amount of mucinous tumors are bilateral. So mucinous tumors are very seldom bilateral in nature. Okay, now also if you see the endometrioid tumors and the clear cell tumor of the ovary, both of them are 40% cases they are showing bilateral, and maximum tumors which show bilaterality, as I showed you, are the metastatic tumors. So if ovarian tumors are bilateral, if in the clinical scenario you see there is a bilateral ovarian tumor, always think it is a metastatic tumor. 100% it is always metastatic in nature. One other thing is that if you compare among all the other tumors, okay, if you see the serous tumors, they account for maximum malignant tumors of the ovary. So if you see, the most common malignant tumor of the ovary are from the serous group. And if you take all the epithelial tumors together, these are the epithelial tumors together, then epithelial tumors of the ovary, they constitute more than 90% of all the malignant ovarian tumors. Is this clear to everyone? These concepts and these points are very, very important, basic questions. Okay. Now we start with the first important type, that is the epithelial tumors of the ovary. Today we are going to cover, if the time permits, we are going to cover the serous tumors and the mucinous tumors of the ovary, the two most important and the most common epithelial tumors of the ovary. Now, as I already mentioned before, that each of the categories of the epithelial tumors, if you see, they can be divided into three main types. They can either be benign, borderline, and malignant. And the most common variety of the epithelial tumor, if you see, the most common ovarian tumor, the nature is they are all adenocarcinomas. Rarely they can be transitional cell carcinomas, or they can be squamous cell also. But the most common variety is your adenocarcinoma. As already mentioned, 60% of the ovarian neoplasms, okay, they are epithelial tumors, and they are comprising more than 90% of the malignant ovarian tumors. Okay, so both of these are important MCQs. So categories of epithelial tumor, as I told you, they can be benign, intermediate or borderline, or they can be malignant. Now, among the benign tumor, remember just few basic things I am telling you. This is the ovary. Okay. Now, if, for example, this part is your tumor and this part is basically cystic and some part is containing the gland. So this is the cystic part. Okay, and this is the part which is containing certain glands also. So that is why this benign tumor is called as cyst adenoma. Okay, I'm just telling you. Now, for example, if this is a benign tumor, only on the surface you are having some papillary projection. In that case, we will call it as surface papilloma. Now, for example, this ovarian tumor, for example, this is one ovarian tumor and it is containing glands, plus there is a lot of fibrosis or fibrotic tissue is there. In that case, the term is cyst. In that case, we are using the term adenofibroma. Now, for example, along with the adenofibroma, you also have one part as a cyst. Then we call it as cyst adenofibroma. So depending on how the content is there, we are using these terminologies. Okay, so don't get, just why I'm telling you, if you see a cyst adenoma, if you see a papilloma, adenofibroma, cyst adenofibroma, think that these are all benign nature tumor. This is what I wanted to tell you. Okay. Now, very important thing is the pathogenesis or the origin of the ovarian epithelial tumors. Very, very important concept over here that you have to understand. And this is with regards to the epithelial tumors of the ovary only. Okay. So with regards to the epithelial tumors of the ovary, if you see, there are two line of thoughts. There are two types of epithelial tumors. So epithelial tumors can either be a type 1 epithelial tumor or it can be a type 2 epithelial tumor. So among the type 1, you are having low grade serous tumors. Okay, you have the mucinous tumors and you have the endometrioid ovarian tumors. Whereas in the type 2, you are having the high grade serous tumor. You have the high grade serous tumor. Now, very, very important point of difference is that they are saying that basically there can be two type of line of origin of the tumors. The type 1 tumors, if you see, they are basically arising from the benign state. For example, they was arising from a cyst adenoma, or they are arising from an endometriosis. So from there, if they arise, they will have a precursor stage. They will come to first as a borderline tumor and then they will convert into this. They are not going to directly convert. Okay, and the origin is basically from the ovaries only. That is the type 1 tumor. So if you see it is written, the type 1 tumors, they are progressing from benign tumors through the borderline stage, and then you are having the low grade tumors. Okay, and these include, as I have said, the low grade serous, mucinous, and the endometrioid tumors of the ovary. Whereas the type 2 tumors, if you see, it is not that always the origin is from the ovary. They are saying that certain origin is occurring from STIC, which is a precursor. Now, what is the full form of STC? It is called as serous
tubal intraepithelial carcinoma.
Intraepithelial carcinoma. Now, you tell me, in the previous lecture, where we have seen something like STIC? Yes, in the previous lecture, we had seen something called as SEIC. And I told you that I am going to, mention this point once again when we are going to read about serous tubal intraepithelial carcinoma. Now, remember, stick, this lesion. Okay, this is basically a precursor lesion. Okay, remember how they are arising. Let me tell you, a part of the fallopian tube epithelium, they are implanting on the ovary. And this part which is implanting is giving rise to a precursor lesion called as a stick, which is giving rise to high grade serous carcinoma. Similarly, if you see, this is a type 2 ovarian carcinoma. Now, similarly, if you remember, SEIC was a precursor lesion which was giving rise to type 2 endometrial carcinoma, if you remember. Yes, type 2 endometrial carcinoma, which was again a high grade lesion just like this. So remember, SEIC is a precursor lesion of type 2. SEIC is a precursor lesion of type 2 endometrial carcinoma. STIC is a precursor lesion of type 2 ovarian high grade serous carcinoma. Both of them, they are the same histological type. They are serous tumors. Okay, histologically, both of them, they are same. And another origin is inclusion cyst. Certain surface epithelium of the ovary might give rise to inclusion cyst, which might directly give rise to a type 2 high grade ovarian carcinoma. Is this very clear? So there are 2 points of origin for the type 2. One is your fallopian tube. Another is your inclusion cyst. In case the inclusion cyst will directly go to the high-grade serous carcinoma, the fallopian tube will first give rise to STIC. After that, you will have the carcinoma. Is this crystal clear to everyone?
Yes, sir.
This origin? Okay. So with this origin in our mind, we will now start with the serous tumors of the ovary. Now, if you look at the serous tumors as a group, I am just saying the serous tumor. They are constituting 30% of all the ovarian tumors, making them the single most group. Now, serous tumor, this is 30%. Remember, I told you serous cyst adenoma plus mucinous cyst adenoma. Only the benign tumors I had taken into account, they were constituting 30%. But over here, the serous tumors means the benign serous plus the malignant serous tumor. Both of them are constituting 30% of the entire ovarian tumor, and it is the single most common group of the tumors. They comprise 22% of the benign ovarian tumor and around 50% of the primary malignant tumor of the ovary. Of all the serous tumor, remember 50% of the serous tumors are benign, 15% are borderline, and 35% are invasive carcinomas. Now, what is the risk factor for the malignant serous tumor, or in general, if they are talking about ovarian tumors? So we know ovarian carcinomas, 90% of them, they are serous. So in the exam, they might not tell you, they might not use the term malignant serous. They will use that all of the following are risk factors for ovarian carcinomas except. So in that situation, it is synonymous that you will have to regard it as the serous carcinoma only. So the nulliparity, family history of carcinoma, heritable mutations in the past, okay, they are risk factors for tumor development. Okay, women who are having low parity. For example, low parity means what? They do not have children. They are married, but they are not bonding the child. Women in the 40 to 59 years of age who have taken the oral contraceptive pills or they have undergone tubal ligation, they have a reduced risk of developing ovarian carcinoma. This is the MCQ which is asked. So in the age group 40 to 59 who have taken the oral contraceptives or undergone the tubal ligation have a reduced risk of developing ovarian carcinoma. Anyone who is having BRCA1, BRCA2 mutation, so they will not only have the breast, but they will also have the ovarian carcinoma. Yes. So BRCA1 mutation is present in about 5% of patients who are younger than 70 years of age with ovarian carcinoma. Now, the estimated risk of ovarian carcinoma in women wearing BRCA1 and 2 mutation is 20% to 60% by 70 years of age is going to develop ovarian carcinoma. Now, the serous ovarian carcinoma, as we see, they are of two main types. They have a low-grade variety, they have a high-grade variety that we have already seen. And how do we differentiate? So low grade is having less amount of nuclear ATP as compared to the high grade. Okay, and low grade tumors, patients are going to survive much more than the high grade patients. Okay, low grade carcinomas may arise in association with the borderline tumors, as I have already mentioned in this diagram. See, the low grade tumors, they are arising after the borderline because they are from this line of differentiation. So they arise in association with the borderline tumors, whereas the high grade lesions, they can arise from in situ lesion of the fallopian tube femore. Yes, what was the in situ? It was called as STIC. It can arise from this precursor STIC, or they can directly arise from the inclusion cyst of the ovary that I have already discussed. Coming to the molecular pathogenesis of this tumor, the low grade tumor, they arise from the borderline tumors. They have mutation in the KROS, BRAF and ERBB2. What is this ERBB2? It is the HER2 gene. Okay, and usually they have wild type of TP53 gene. Wild type means the normal sporadic type. Wild type is the normal sporadic type. Okay, so basically these are the basic important genes which are affected in low grade tumors. In high grade tumors, remember, very high frequency of TP53 mutation. Here no TP. Wild type means your normal sporadic TP53. Over here, very high TP53 mutations are present, and these lack mutations in either KROS and BRAF, which is present over here in case of low grade tumors. Okay, another a number of other genes are involved, like RB or PIK3CA might also be involved. Also, whatever tumor which is arising in the setting of BRCA1A and 2 mutations, they are also high grade tumor with TP53 mutation. And remember, this BRCA1-2 mutation, they are very rare in sporadic high grade serous carcinoma. They only arise in the setting of familial tumors. So if you look at the morphology, again, I am going to show you the morphology in the terms of benign, borderline and malignant. So this is the benign serous adenoma. What is very important, you can see the surface of this tumor. It is highly what? It is highly smooth and it is
and glossy.
glossy, glistening in nature. Can you see any epithelial thickening? You cannot see any epithelial thickening over here. Okay, so you see a unilocular means a single locule is there, a single cyst is there. For example, a single cyst is there. They don't have any partitions. So this is multilocular. And if no division is there, it is called as unilocular. Smooth and glistening surface is there, as you can appreciate over here. Or even if some papillary projections, even if it is present, they are very small, like surface papillomas. This is your borderline tumors. If you can see on the surface, you can see they are opened and you can see certain delicate papillary tumor growth. You can appreciate the delicate papillary tumor growth on the inside after cutting it open. Also, another borderline tumor, you can appreciate a lot of papillary growth, as you can appreciate over here. Okay, they are looking like papilla only on the ovarian surface. Now, borderline serous tumors, they are associated with increased number of papillary surface projections, as we can appreciate from these diagrams. Now, this is the malignant serous tumor. These will become very large, bulky. Now, very important thing, you will see that these malignant tumors, they are far more solid and they are larger areas. So larger areas of solid or papillary tumor growth, and the tumor shows irregularity. They are quite heavy. Okay, and they will show fixity to the underlying capsule. They will be fixed to the overlying capsule. So this is how grossly you are appreciating the serous tumors. And usually the serous tumors, they show papillary nature. Okay. Okay. Now this is the microscopic feature, as we can appreciate over here. So you can see this is the benign tumor. Okay. This is the benign tumors. For example, this is one benign tumor. Now this benign tumor, you can see they are lined by a single layer of columnar epithelium. So they will show cyst lined by a simple columnar epithelial layer. That's it. Now, sometimes this epithelia can show stromal papillae. So they are extending in the form of papilla. Can you appreciate? So sometimes they might show extension into the stromal papillae in this way, but there is no invasion. Stromal papillae lined by columnar epithelium is present. And epithelial cells, they retain abundant amount of cilia, because the presence of the cilia is going to indicate the benign nature of the tumor. Okay, so this is about the microscopic features of the benign tumor. Now, this is the borderline tumor. Very important. They will have an increased architectural complexity over here in case of borderline serous tumor. And also there will be epithelial cell stratification. See this, if you see this lining, this is your simple columnar lining. Stratification means one cell on top of the other.
Layer over layer.
Oh, that is the stratification that is there. So epithelial cell stratification is present in the borderline tumor. Now there is a hierarchic branching pattern. This is a very important point. What is the meaning of hierarchic? See this is larger in size. As you go above, they will become more smaller and smaller and smaller. So as you go up, there's a hierarchical branching is there. From larger branching, you get a smaller branching. Now mild amount of nuclear atypia might be present, but again, what is very important, no stromal invasion is there, which is differentiating this borderline serous tumor from your malignant tumor. Now this is again a borderline serous tumor, but this is the micropapillary variant. Okay, this is also called as the micropapillary variant because the papillas, they are very small. Okay, they are very, very small in nature and they are elongated. Now it is believed that this term, this micropapillary variant, it is quite intermediate between the borderline serous tumor and low-grade serous carcinoma. And sometimes when this malignant micropapillary variant, when it is going to show invasion into the stroma, then they become low-grade serous carcinoma. So usually it is regarded, this micropapillary variant of borderline serous tumor is regarded as a direct precursor of the low-grade serous carcinoma. Remember, if you see this morphology, they can act as a precursor of low-grade serous carcinoma. This is the micropapillary variant. Okay, very small but elongated papillas are appreciated over here. This is the high-grade serous tumor showing more complexity, and the most important feature, if you see, can you see this?
Invasion of stroma.
So invasion of the underlying stroma is present. This is the stroma as we can appreciate from this diagram. This is the classical stroma as we can see. So high grade serous tumor, if you see, they are showing more amount of complex growth pattern with widespread infiltration of the underlying stroma. If you look at the individual tumor cells are showing marked tumor atypia, pleomorphism, atypical mitotic figures along with multinucleation. And the precursor to the high grade tumor, very important exam question, is stick. Okay, high grade serous, also called as type 2 ovarian tumors. It is stick. It is a serous tubal intraepithelial carcinoma. The cells over here are identical to the high grade serous tumors but without invasion. That is the precursor of the high grade serous tumor, that is called as the stick. Okay, now look over here. This is the serous carcinoma. It is characterized by the presence of confluent papillary growth. So these are all papillas and they are confluent, means they are back to back arranged. Can you see any space in between? These are the fibrovascular cores that you appreciate. So this is the classical picture of the serous papillary carcinoma. Serous papillary carcinoma it is. Okay. Now this is another high power view where you can see that the cells are growing in sheets, papillae, and they have large vesicular nucleus with prominent nucleoli is characteristic feature of these cells. Now we have the low-grade serous carcinoma. Now in case of low-grade serous carcinoma, now invasion is 100% there. But what is very important, whatever papillae that you see, these are very small papillae. These are called as micropapillary fronts surrounded by clear spaces. So you can see certain clear spaces and multiple micropapillary fronts, which are the classical feature of low-grade serous carcinoma. So nuclear atypia is less as compared to the high-grade tumors. The nuclear atypia is less and the mitotic figures are few in this particular case. Okay. Now, some general features of the serous tumors of the ovary. If we look at some general features over here, what are the general features? You will see concentric calcifications, also called as psammoma bodies, are common in all types of serous tumors, but they are not specific for serous tumor. Now, ovarian serous tumor, whether it be low grade or high grade, they can spread to the peritoneal surface. Okay, they can spread via the peritoneum and the omentum, and they can show widespread spreading. They can present with ascites, and some of the tumors, they arise from the fallopian tube, that is called as the STIC, which I've already discussed, and some of them can directly arise from the peritoneum. In that case, we call it as the primary peritoneal serous carcinoma. Now, the borderline tumors of the ovary, they can invade the peritoneum as non-invasive implants, which might either be asymptomatic or they might spread slowly and cause intestinal obstruction as well. Now, low-grade ovarian tumors, even after they are spreading outside the ovary, okay, they progress very slowly and the patients may survive relatively long, whereas the high-grade tumors are highly metastatic at the time of diagnosis. If you look at the 5-year survival rate for borderline tumors, which are confined to the ovary, is 100% survival, whereas malignant tumors confined to the ovary, 70% is the survival 5-year. If they have spread outside the uterus into the peritoneum, then the survival rate is going to fall to 90% in case of borderline tumors, and in case of malignant tumors, it will be around 25% only. So just see, if the tumor is going outside the uterus, see the survival rate is going down so much from 70 to 25%. Now, very important is the immunohistochemistry of serous ovarian tumors. They are positive for CK7. Very, very important marker of serous ovarian tumor is your CK7, whereas they are negative for CK20 and CDX2. So what is the importance over here? Let me tell you. There is space over here. If you see the primary ovarian serous tumor, okay, they are a type of adenocarcinoma. Yes. And the colorectal carcinoma, they are also a type of adenocarcinoma. So you might get mixed up with the two. So these tumors, you will see, they are always CK7 positive and they are CDX2 and CK20 negative. This is an important exam question. Whereas colorectal carcinoma, if you see, they are CDX2 positive along with CK20 positive. Always remember this point of difference between the ovarian tumors, how to differentiate from metastatic colorectal tumors. Is it very clear to everyone? Okay. Another feature which is present in most of these serous tumor is the positivity for WT1. Okay, it is helping to differentiate the serous tumors from other tumors like the endometrioid and the clear cell. Now, high grade serous carcinomas, they are positive for TP53, they are always positive for P16, and they are always positive for HMGA2A. So these are three important markers of high grade serous tumor. And also all the serous tumors are also positive for PAX8. So another very important, two important markers of ovarian serous tumor will be WT1 and PAX8. So remember this three important markers, CK7, WT1, PAX8 are important ovarian serous carcinomas, and these two markers are important to differentiate from colorectal carcinomas. Okay, so I think today we will stop over here, or should I complete mucinous tumor? Should I complete mucinous tumor?
Complete, sir.
Okay, let us now complete the mucinous. Okay, let us complete the mucinous tumor also. The next important tumor over here is the mucinous tumor of the ovary. If you look at the mucinous tumor of the ovary, they are accounting for approximately 20 to 25% of all the ovarian neoplasm. It occurs in the middle adult life. It is rare before puberty and after menopause. Vast majority of these tumors are benign and borderline. So unlike the serous tumors, as I told you, okay, so a high percentage of serous tumors, they are malignant in nature. In fact, the epithelial serous tumors, they are constituting 90% of the malignant tumors of the ovary. Whereas the mucinous tumor, if you see, vast majority, they are benign or borderline in nature. The primary ovarian mucinous carcinomas are uncommon and account for approximately 3% of the ovarian carcinoma. It is very, very less. Whereas over there, they were constituting more than 90% of the ovarian carcinoma. The most common ovarian mucinous tumor will become your mucinous cystadenoma. And over here, they are having mutation in only one important gene, that is the KROS proto-oncogene. And the incidence increases according to the histology. Around 58% benign tumors are positive for KROS. 75 to 86% is positive in KROS positivity seen in borderline, and around more than 85% of positivity seen in carcinoma tumor. So versus the serous ovarian tumor, the surface of the ovary over here is rarely involved. It is not involved. Just like in case of your serous tumor, the surface was widely involved. Over here, it is not that. And only 5% of the primary mucinous cystadenoma and mucinous carcinomas are bilateral. So majority are, these are unilateral tumor. And I showed you the serous tumors, they are much more bilateral compared to the mucinous tumor. Already discussed this point. So grossly, if you see these tumors, they are producing very large cystic masses. See, this is one cyst filled with mucin, another cyst. So these are multicystic with multiple, and they are containing this glistening. What is this glistening substance called as? This is the glistening mucin or the mucus. Now the weight of these tumors extend more than 25 kgs. These are multiloculated in nature, filled with a sticky gelatinous fluid rich in glycoproteins. In all these tumors, whether it be benign, borderline or malignant, they will have the same appearance. A multilocular, multicystic, separated by the delicate septa and presence of glistening mucus as seen in this diagram. Now, this is the benign mucinous tumor. Now, as you can appreciate now over here, this is one cyst, this is another cyst. They are separated by this fibrovascular septa. So over here also there are multiple cysts, okay, and they are separated by this septa. Now, very important, they are lined by a single layer of columnar epithelium, and this columnar cell is very much like your gastric or intestinal columnar cells, and they contain the goblet cells also. What is this product over here? What is this thing? This is the mucin only that has come under the histopathology. This part is the mucin. This is again the mucin. So the benign mucinous tumor, multilocular cystic neoplasm containing the mucin, lined by a single layer of columnar mucinous epithelium. Look at this columnar cell. Can you appreciate this columnar cell? How they are? They are intestinal variety. Okay, they are intestinal variety. Tall columnar cell with clear cytoplasm with bland basal cell nucleus. See, in case of mucinous tumors, they can have two types. One is the intestinal type columnar cell and one is endocervical. But 95% cases, or predominantly, they have this intestinal type columnar cell only with bland basal nucleus. Now, the borderline mucinous tumor, if you see, just like we had seen the borderline serous, this is showing more complexity. Okay, this is more complex tumor. If you see, they are showing more complexity. Now, just like the borderline serous, again, they are having complicated glands and papillae. Okay, so they are having glands also, plus some of them are showing papillary growth also. There is no stromal invasion whatsoever. There is again epithelial stratification will be there, tufting will be there, papillary growth will be there, lot of mucin is appreciated. And over here, these glands are looking very much like the tubular and the villus adenoma of the intestine that we have read. Yes, everyone will agree with me with that. Okay. If you look at the individual tumor cells, why am I saying they are intestinal variety? Can you see these cells? What are these cells? Yes, these are the goblet cells. These are the goblet cells that is present in the normal intestine. So the borderline mucinous tumor of the intestinal type, which is the most common variety. Coming to the mucinous carcinoma, very importantly, you will see the invasion of the stroma. And how are we saying the invasion of the stroma? Because you are seeing the confluent pattern of growth with back-to-back glands. Anywhere where the gland is back-to-back with no intervening stroma, what do I say? I tell you that that means there is an invasion of the stroma.
Malignancy.
Malignancy. So glands are crowded, more complex, intestinal type predominant with back-to-back arrangement with stromal invasion. So the 10-year survival of the stage 1 non-invasive intraepithelial carcinoma is more than 95%, and the frankly invasive malignant tumors, the survival is more than 95. So they have a very good prognostic. Okay, very good prognosis is there. Even frankly invasive malignant tumors shows more than 90% survival. Now, looking at the immunohistochemistry of the same, very, very important thing, as I told you for the serous tumors also. So for this, again, we have to compare. See, glands are present here also, and glands will be present in the metastasis from the lower GI tract, that is the colorectal carcinoma. As I told, the ovarian tumor will always be CK7 strong positive, they will be CK7 negative, whereas the GI tumors will be CK20 diffuse and CDX2 also, they will be strong positive, whereas over here they will be negative. This we have already discussed. Now, for example, if inside the ovary a metastatic cervical carcinoma comes in, then in the previous lecture in cervical carcinoma, we had seen one of the marker was P16. So that is going to differentiate the primary ovarian from metastatic cervical carcinoma. And again, from the pancreas, the pancreatic carcinoma will show loss of DPC4 staining. So this is how you can differentiate the ovarian mucinous tumor from the other metastatic tumors. Is this very clear? Okay. Now there is one more condition called as pseudomyxoma peritonei. Now remember, this is a benign condition. What happens that inside the peritoneum, the lot of amount of mucin that was secreted that enters the peritoneum and they form certain implants, and they will cause a lot of adhesion. If extensive amount of pseudomyxoma peritoneum will occur, it will result in intestinal obstruction and death. So historically, it was thought that these cases were because of the spread of primary ovarian mucinous neoplasm. But now in almost all cases, the source of pseudomyxoma peritonei is extra ovarian source. Usually it is the appendix. Okay, remember, and majority of the primary ovarian mucinous neoplasm, they are unilateral in nature. Bilateral presentation of mucinous tumor, anywhere if you see bilateral mucinous tumor, always think that it is a metastasis that I've already discussed before. So this is the pseudomyxoma peritonei, as we can appreciate. See, all the mucin has spread throughout the peritoneum. Okay, all, and it can lead to intestinal obstruction, and finally it can cause death. So this is your pseudomyxoma peritonei associated with your primary ovarian mucinous tumors. Is this very clear to everyone? So the next important epithelial tumor is your endometrioid variety of ovarian tumor. Now this endometrioid variety of ovarian tumor, it is accounting for 10 to 15% of all the ovarian cancers. It accounts for 10 to 15% of all ovarian cancers. Okay. Now, over here also, just like in any other epithelial tumor of the ovary, we are having benign, borderline, and malignant tumor. But in category of endometrioid tumors, the benign and the borderline tumors are quite uncommon. It is not very common to find these tumors. Third thing is that these tumors are proliferative, hyperplastic, and they, these resemble like the malignant endometrium. Now, do you remember the endometrial carcinoma that we had read in the previous classes that we have completed? So this endometrioid variety of carcinoma is very much like the proliferative endometrium, or endometrium showing hyperplasia, or even the malignant endometrium. So it draws its resemblance from endometrium carcinoma. Remember, this is not endometrial ovarian tumor. It is endometrioid. Endometrioid, the term means that it looks like endometrial, but it is not completely endometrial. So it is called as endometrioid, which is very much similar to the proliferative, hyperplastic, and malignant endometrium. Approximately, if you see, around 15 to 30% of the ovarian endometrioid carcinomas, they are accompanied by carcinoma of the endometrium. So very, very important. Around 15 to 30% of ovarian endometrioid carcinoma, they are accompanied by carcinoma of the endometrium. And in such cases, the ovarian carcinoma, the ovarian endometrioid carcinoma is arising via metastatic spread from the primary endometrial carcinoma in the uterus. So try to understand, in 15 to 30% of the cases, okay, ovarian endometrioid carcinoma is happening along with the carcinoma of the endometrium. Is this very clear? And in such cases, the carcinoma of the ovary is nothing but a metastasis from the primary endometrial carcinoma in the uterus. Is this point very clear? Now, in around 15 to 20% of the cases, the endometrioid carcinoma will coexist with endometriosis. So in around 15 to 20% of the cases, the endometrioid carcinoma, it is coexisting with endometriosis. So for example, in the ovary, I hope you all remember what is the meaning of endometriosis. Yes, anyone can tell me what is endometriosis?
Endometrial tissue outside the ovary.
Very good. So over here, in around 15 to 20% of the cases, the endometrioid carcinoma is coexisting with the endometriosis. That means in the same ovary, you are finding endometrioid carcinoma. Along with that, focus of endometriosis is always there. Is this very clear? Now, such carcinomas, such cancers, they occur a decade earlier. So very, very important thing is that those kind of endometrioid carcinoma, which is associated with endometriosis, okay, such kind of endometrioid carcinoma occurs a decade earlier. So ovarian endometrioid carcinoma is very much similar to endometrial carcinoma of the uterus. Why? Because both of them share the same molecular pathogenesis. So there are frequent alterations involving the PI3K-AKT pathway signaling. So if you remember, we have discussed in detail, okay, the endometrial carcinoma, wherein we have discussed the PI3K-AKT pathway, the mutations in the PTEN, tumor suppressor gene, PIK3CA, ARID1A mutation, KROS, mismatch repair gene mutation. So all these mutations that were seen in endometrial carcinoma are similar to that, are very much same in endometrioid ovarian carcinoma as well. Okay, and just like in case of endometrial carcinomas, in the serous high-grade endometrial carcinomas, we were having TP53 mutation. Over here also, TP53 mutation is present in poorly differentiated ovarian endometrioid carcinoma. So because they are sharing the same molecular pathogenesis, so basically, so molecularly they are connected with each other. This is what I wanted to say. Coming to the morphology of the endometrioid tumor, so we have to distinguish the endometrioid tumor from the serous and the mucinous variety. So it is very easy. Why? Because in case of endometrioid tumors, you are having the same tubular glands resembling the benign or the malignant endometrium. So the kind of endometrial glands that we see in the endometrial carcinoma, it is very much resembling that. There is no papillae. As in case of serous tumors, you are having papilla. Over here, you are having mucin. Those things are not present. So grossly, if you see, these are solid cystic tumors, approximately 10 to 20 centimeters in diameter, and they are showing areas of hemorrhage and necrosis. Around 40% of these tumors, they are bilateral. Around 40% are bilateral. So already we have discussed about the bilaterality of several tumors in the basics lecture. So microscopically, they are very much similar to the adenocarcinoma of the endometrium, showing glandular or papillary architecture. And very important, what did I tell you? That when the glands are present, the only indication of invasion of the stroma is what? The characteristic back-to-back pattern of gland arrangement, okay, or the confluent pattern. So the grading of endometrial carcinoma, do you remember the grading? There was grade 1. There was grade 2 and grade 3. So whatever grading we have read for endometrial carcinoma is similarly applied for endometrioid carcinoma of the ovary. And just like endometrial carcinoma over here also, in the endometrioid carcinoma of the ovary also, in 25 to 50% of the cases, you might find squamous differentiation as well. Is this point crystal clear? Okay. Now, if you see over here, this is the classical. Now, as I told you, any epithelial tumor is having three parts. One is your benign, borderline, and malignant. So this is the benign counterpart of the endometrioid tumor, wherein can you see these glands and can you see the stroma? They are very much similar to the endometrial tissue. So these are proliferative glands, as I have already shown you. These look like proliferative normal glands. There is no back-to-back arrangement. The cells look very benign and they look endometrial types of cells. So what you see the presence of endometrial types of benign glands lined by benign endometrial cells in a background of dense fibrous stroma, so are called as adenofibroma. This is the second important diagram. This is the borderline endometrioid tumor. So you can see there is some complex architecture over here. And also there is a stratification. The cells are present on top of each other. There's a pseudo stratification which is present. The crowding is more as compared to the benign variety. Okay, but again, there is no invasion of the stroma because back-to-back arrangement is not classically present over here. And thirdly, we have this is the most common variety. In the endometrioid carcinoma, the benign and borderline are less common, but the endometrioid variety are more common. Now, there is a glandular architecture everyone can appreciate. This is one gland over here. This is another gland, as we can appreciate over here. And what is very important in between them, is there any stroma present? No. So there is a classically what we call it as a back-to-back arrangement, confluent pattern of growth, which is indicative of invasion and carcinoma. So this is endometrioid carcinoma. Okay, is it very clear to everyone? Now, one very important part over here is what is the immunohistochemistry. Now, remember, in all kinds of epithelial tumors of the ovary, the cytokeratin and EMA will come out to be positive. And among cytokeratin, they are always CK7 positive and CK20 negative. Now, I've already explained you that CK20 is positive only in case of colorectal carcinomas or from those that are coming from the gastrointestinal tract, any kind of metastasis coming from there. And one specific marker for this particular ovarian tumor is your ER and PR. They are serving as the specific marker of this tumor. Very clear to everyone? Coming to the next important epithelial tumor of the ovary is your transitional cell ovarian tumor. So very important thing about the transitional cell tumor of the ovary is that these are containing neoplastic epithelial cells, which are very much resembling the urothelium. Urothelium is the lining of the urinary tract, starting from the pelvis of the kidney, going down into the ureters, okay, then into the bladder and then urethra. So the lining of our urinary system, that is the urothelial lining. So such kind of epithelium is seen in case of your transitional cell tumor of the ovary, also called as Brenner's tumor. Okay, and usually these tumors are quite benign in nature. They comprise around 10% of all the ovarian epithelial tumors. These are also known as Brenner's tumor. This transitional cell tumor is also called as Brenner's tumor. And just like any other epithelial tumor, we are having benign, borderline, and malignant. So over here, unlike the endometrioid variety, if you see, the benign and borderline varieties are far more common. Now, the benign variety is characterized by the presence of nest of transitional epithelial cells, which are surrounded by a fibrous stroma. That is your benign variety. Nest of transitional epithelial cells surrounded by fibrous stroma. So let me show you a diagram. So can you see over here? This is the classical transitional epithelial cell that we can appreciate over here. This is the classical. Okay, so this is your nest. This is the nest of transitional epithelial cells. And what is this surrounding them? This is your fibrous stroma, which is surrounding this particular cell. Also, sometimes you can see there are some cells which have undergone metaplasia. So from transitional like cells, they have become what? They have become endocervical, as we can appreciate over here. So they have become endocervical like mucinous cells. Okay. Now the second important histological type, that is the borderline variety, they are very much similar to the low-grade transitional cell carcinomas of the urinary tract. So over here, the only difference is that the cells are multi-layered. As in any borderline, you will see stratification. So over here also there is there. So you see a multi-layered transitional epithelium and they show mild nuclear atypia. So let me show you with the help of a diagram. So this is your borderline variety of Brenner's or transitional cell tumor. So over here, you can see that there is a multi-layering. There is a classical multi-layering of the transitional epithelium that we can appreciate over here with mild nuclear atypia. So this is very much like the low-grade transitional cell carcinoma of the urinary tract. And the third important variety, that is your malignant Brenner's tumor, they will infiltrate the stroma. And they are classically resembling the high-grade transitional cell carcinoma, wherein the nucleus shows all the atypical pleomorphic features. Now the diagnosis, remember that in case of your malignant Brenner's tumor, always remember that for making a diagnosis of malignant Brenner's, the area of carcinoma has to be there, but that is not enough. Along with the area of carcinoma, you should have some area showing benign or borderline features of Brenner's tumor. Only then you are going to call it as malignant Brenner's tumor. So for a diagnosis of malignant Brenner's tumors, always remember just the carcinoma portion is not enough. Along with that, in the background, a focus of benign or borderline Brenner's has to be there so that we can call it as malignant Brenner's tumors. In case the carcinoma part, okay, if in case the carcinoma part or the malignant transitional epithelium is comprising more than 50% of the tumor, okay, of the total tumor, if it is more than 50%, then instead of calling it as malignant Brenner's tumors, we will call it as transitional cell carcinoma of the ovary. Always remember this part. So when the malignant epithelium is present along with the benign and the borderline Brenner's, and the malignant epithelial tissue is less than 50%, we will call it as malignant Brenner's tumor. But if the malignant portion is more than 50% is your transitional epithelium, then we will call it as transitional cell carcinoma of the ovary. A very, very important question asked in AIMS. Okay, it was asked in AIMS, INICET. Okay. Now, grossly, if you see, basically these tumors, that is the Brenner's tumors, they are unilateral. They are very well circumscribed tumor, and classically they have a pale yellow appearance. They look solid or they look fibrous. Okay, they are small to medium sized. And as these are epithelial tumors, so they are CK7 and EMA positive. But there are certain important markers that is highlighting the urothelial line of differentiation. That is, they are positive for uroplakin 3, thrombomodulin along with GATA3. So this is your gross image, as you can appreciate. So over here, this part that you can appreciate, that is a pale yellow solid part. Okay, this part, if you see, this is the Brenner's tumor. And Brenner's tumor, in many areas, they are associated with a germ cell tumor. On the left-hand side, this area is a teratoma actually. Okay, this is a cystic teratoma. We will discuss in details about teratoma later on in the lecture. Okay, is this very clear about Brenner's tumor? And this benign, borderline, and transitional cell carcinoma we have already discussed. Remember, the term transitional cell carcinoma will only be used when the tumor mass, you can see that there is invasion of the stroma. And over here, to call it as basically transitional cell, more than 50% of the epithelium should be transitional type, as we see over here. If, for example, this malignant tissue is less than 50%, in that case, we will call it as malignant Brenner tumor. The next important epithelial tumor is your clear cell carcinoma of the ovary. Now, clear cell carcinoma of the ovary, initially it was thought to be of mesonephric origin. Okay. But clear cell tumors, they were shown to arise from either areas of endometriosis or even the surface epithelium. Now, more than 90% of all the clear cell tumors of the ovaries, they are carcinomas. So the amount of benign and borderline tumors are very less. And as the name suggests, these are very large epithelial cells having abundant amount of clear cytoplasm. This is an appearance which is very much like the hypersecretory gestational endometrium. Now, also remember, these tumors can occur sometimes in association with endometriosis or endometrioid carcinoma of the ovary. Very, very important. So these can occur sometimes in association with endometriosis or endometrioid carcinoma of the ovary, and they very much resemble the clear cell carcinoma of the endometrium. If you remember, endometrial carcinomas were of two types, type 1 and type 2. The type 2 was the high grade variety, serous variety. Over there, one of the other tumor was the clear cell carcinoma of the endometrium. This is very much similar to the clear cell carcinoma of the endometrium. And now, very important, because they have an association with the endometrioid carcinoma. Therefore, in line with this idea, the most common genetic aberrations are also similar to the endometrial carcinoma only. The PIK3CA, ARID1, KROS, P10 mutation, they are very much similar to the endometrioid carcinoma of the ovary as well as the endometrial carcinoma of the uterus. Okay. Now, very important thing that that overall 5-year survival over here is 90%, but in advanced stages, okay, there has a very poor outcome. Okay. Now, basically, we have to understand that in general, they have a worse prognosis as compared to other epithelial tumors. So grossly, these are very large tumors, around 10 to 30 centimeters in diameter. They are bilateral in 30% cases. They can be solid and partly cystic. Microscopically, they have clear cells, and they also have cells with granular eosinophilic cytoplasm, or they have hobnail cells. So clear cells are completely clear like this. Eosinophilic cells with eosinophilic granular cytoplasm will have granules like this. And there are certain cells which are hobnails like this. Okay, this is called as hobnailing. The cells, they tend to come out. That is called as hobnailing cell. This is a normal cell. These cells tend to come out. That is called as hobnailing effect. I will show you. So this is one very important diagram that you can see. So you can see some of these cells are completely clear, as we can appreciate over here. Yes, some of them are completely clear. Some of these cells are showing eosinophilic granular cytoplasm, and some of them are showing this kind of hobnailing. So there's a mixture of cells actually. Okay, there's a mixture of cells, but in general they look very clear. So this is a characteristic clear cell carcinoma of the ovary. This is another diagram, as I can, this is a tubulocystic pattern clear cell tumor, wherein you can see the multiple tubules over here, which are lined by the cuboidal epithelium, and they have clear cytoplasm. Now, the immunohistochemistry that is very important for this is that these are, again, they are CK7 and EMA positive, showing their epithelial nature. But unlike the endometrioid tumor, they are absent for ERPR. Other marker that they are positive for over here, as you will see, is HNF1 beta, napsin A, and AMACR. These are some of the specific markers for clear cell tumors of the ovary. So with this, we have completed in details about the ovarian epithelial tumors of the ovary.